On this week's episode, we are having a conversation on palliative care and how this approach can enhance one's quality of life. Guiding us in this conversation is Dr. Mulé. Dr. Mulé graduated from the Memorial University in Newfoundland in 2002. He obtained his training in pediatrics and emergency medicine at Albert Einstein College of Medicine in 2005 and 2008, respectively. He moved to Ontario in 2010 as an emergency physician and acquired a training and credentials to practice in palliative care and also hospice medicine in 2017. He's currently a physician at Northumberland Hills Hospital. It is with great pleasure that I welcome you today to enjoy this conversation with Dr. Mulé. Welcome, everyone, to another episode of My Compassionate Heart. This week, we're having a discussion about palliative care and how to improve the quality of life for individuals with palliative care. I'm so happy to have with us this conversation this week Dr. Mulé. He's going to speak to us more about palliative care, and we're going to have a great discussion. Grab a cup of coffee, tea, sit with us, enjoy this discussion today, and we hope that you would learn from it and share it with others. So, welcome again, Dr. Mulé. Thank you so much for taking the time to be with us today and having this conversation.
Well, thank you for having me. It's my pleasure.
Awesome. So, the first question that I have for you, I want you to describe to me or explain to our audience what is palliative care and how does it differ from hospice care?
For sure. So, palliative care and hospice care essentially one can potentially lead into each other, and I'll explain why. So ultimately, when an individual is diagnosed or given a diagnosis, or told, of course, that there is an illness that will challenge life, that will compromise how they can live, that will require intervention, medicine, support, and treatment, and then ultimately can affect and limit how long they will live, it is essential to offer and incorporate palliative care. So palliative care ultimately focuses on assisting that individual with what this diagnosis has done to them. Traditionally, palliative care has been incorporated as a transition point, and that is unfortunate because that is not the essence of the philosophy. It is a form of medicine that should work synergistically with the discipline that is ultimately helping this patient manage this diagnosis, whether it's heart, lung, kidneys, cancer, and so forth. Hospice care is a complement or an extension of palliative care. When that individual is forced into end of life, and there are different ways of defining end of life, whether there's a timeline there, whether there's a functional status there, whether there is clear progression of the diagnosis compromising the individual's ability to live and survive. But yet, the focus is helping that individual with this version of their life, at this stage of life, and to help them still manage how to live as well as they can, and to prepare for the inevitable, which is dying. But the focus is always about living and to optimize how to live. If we were to go back and understand where the word palliative comes from, its origins, from what I understand, is of there are Latin. It comes from a Latin word, which means to cloak. And interestingly enough, today I heard a phenomenal analogy that I can refer to.
Yeah.
So, if it is raining and you are in the rain,
Yes.
and you are being exposed to the rain, I come to you with a cloak and cover you. Okay? Therefore, I'm there not to necessarily deal with the rain itself, but yet to help you endure what the rain is doing to you. And that, in essence,
Mm.
is palliative care.
Wow.
Okay. And so that to me was an amazing way of explaining what we try to do.
Mm-hmm.
As an individual might want to deal with the rain, let's say the oncologist is trying to help you manage or help the patient manage the diagnosis that is symbolically this rain pouring on you. The palliative physician comes and supports that patient as they try to endure what the diagnosis has done to them or is doing to them. And so, again, it works alongside and helps. It's not a transition point. It should never be. Unfortunately, this it has been introduced as such, and it is our job to step back and say, what do you need as an individual to live well? And therefore, I can support you as a palliative physician. Depending on where you are in life, I will support you as a hospice practitioner.
That's excellent. And I love that you pointed out that it's really not meant to be a transition point, that it's really meant to be strategies and tools to help support that individual to live their best life or best quality life that they can have. And I really love also your description of the rain, the rain pouring
Well,
and
that was fortuitous that I heard that today. I was like, oh, I'm going to use this. Okay, right. So it was just so beautiful. I'm like, oh, yeah, it's pretty cool. So we're very, we romanticize care. Okay.
yes,
Okay, all right.
yes,
Because at the end of the day, it's humanity. And so
yes.
our focus is humanity and how that individual is suffering. And so
Hmm.
that is a big component of my care. How can I help you address suffering? The medicine is easy, right? It's so easy. Where I can, yes, support or address a symptom by asking you to consider trialing this medicine. But yet, the more challenging part is helping you because of your humanity. And so, my morals, my kindness, my interest, my devotion, these are the things that I have to, as a clinician, have to kind of regroup and utilize to help someone endure what a diagnosis is doing.
Doing,
And
yes,
so, yeah, so it's again to step back. It's about living as well as you can. And
yes.
unfortunately, this is my introduction um, to this concept with almost every patient I am exposed to, because it's been palliative care or palliative medicine or hospice care, hospice medicine has unfortunately been defined historically as a point of no return, as a as oh, we can't do anything anymore, so this is what you need to do, and that's not the case. That's not the
Yeah,
case at
yeah.
all.
And
And
I think it's
so,
important that they know that because it's
yeah,
really supporting that individual to live as well as they can, as you said, right? It's not
for
about
sure.
getting to the end but it's how do you support that individual based on what's happening with them clinically? How do we support you to have the best quality of life? And I think
For
that's
sure,
truly
and
what it
it's
entails.
up to the individual. It's not up to the system. It's not up to the clinician, right? Whether it's nurse or
Yes.
physician or nurse practitioner, it's up to the individual, and it's about asking the patient what is important to you and how do you want to be cared for and how do you want to be spoken to and how do you want things to be explained to you, right? And
Yes.
so I think that individual in their uniqueness, okay, ultimately drives the care, okay.
Yes.
And palliative medicine and hospice medicine, uh, they they highlight that. They really they put a light on that, and I think that's the beauty of this type of care. And lots of people do it.
Yeah.
They are doing it all the time, and
Yes.
so it's a matter of just letting the patient know, look, you've been receiving this since day one. And it is phenomenal because unfortunately, um, palliative care, okay, has been made. It's almost referred to as like as a stage,
Mm.
and this is incorrect. When we say, "Oh, the patient is palliative,"
Mm.
and that is incorrect. And I understand sometimes jargon just makes it easy to communicate amongst people. For sure, I get that, right?
Mm.
But it's incorrect in the sense where you know this type of care has ultimately become a label,
Yeah.
and that's unfortunate. So
Yeah.
I don't say to an individual, "Oh, you're a cardiology patient. Oh, you're oncology now. Oh, you're neurology now." And so it's not the same. And we need to kind of step away from that, which is hard. It's very difficult, as you can imagine, to change culture, to
Yes.
change attitude.
Yes.
But yet, it's just every individual is an individual, so we should approach them as such.
As such, and that's great that you brought that point up. They're an individual, and seeing them for their uniqueness and for who they are is important to that care. And I think you also brought up a point that's of great importance with care overall. It's making sure that's patient centered. The patient is
For
the
sure.
driver. I love
Yeah.
to say, they're the ones in the driver's seat. We're passengers along with
Yeah.
them. And so
Yeah.
they're in control of how they guide that care. And so keeping them at the center of care is very, very important. So, with that being said, what would you say are the primary goals of palliative care? What are clinicians hoping to accomplish when you meet a client or a patient
Mhm.
for the first time
Yeah.
with this approach?
So medicine has become a transaction, right? Where you have this, I have that. Okay, that's kind of what has occurred, right? You're the last person you want to ever meet is a physician, of course, right? Because that means that you have a challenge. And it's funny. Today I met someone. I was having this conversation. He goes, I don't like police, and I don't like doctors." I go, "Why?" And I knew what he was going to say. He goes, "Well, I need it when I'm in trouble and I have a problem. I need the police to help me. When I'm in trouble and I have a problem, I need a doctor to help me." Right. So I guess we're
Yeah,
generalizing here, of course. But my point
yeah,
is that um, when an individual is compromised, whether it's their environment, their security, their health, okay, right, you have to rely on someone, whether it's a nurse, okay, whether it's a nurse practitioner, whether it's an occupational therapist, a physiotherapist, a physician, and so forth. And so relying on another individual to help you live the way you want to live is overwhelming and exhausting, taxing. Ultimately, as a palliative clinician, my job is to help you live well. Okay. And so if I'm there to add to the conversation, addressing this diagnosis that has compromised how you live, how you think, how you plan, then there's a role for me. If there has been a change in how you're living because of symptoms that are overwhelming you because of the diagnosis or the treatment that has been implemented to help manage the diagnosis, then there's a role for me. Okay. So ultimately it's about living as well as you can, and I'm there to assist you as an individual experiencing this.
that's good.
That's how I approach every patient.
Yeah. And I think that's a great approach. I'm just wondering what alternative therapies are often incorporated into palliative care and into the management of, like,
Yeah.
for example, you said there's a diagnosis, the individuals experience certain symptoms, they're presenting with certain symptoms.
Hmm.
What kind of alternative therapies or approaches do you
For
use
sure.
as part of your palliative approach in supporting individuals?
Yeah, yeah. So I think, like I mentioned, the medicine is easy. The individual is complex, and so there are many components to the individual that need to be address. So that psychosocial
Mm-hmm.
component, right? So how is that individual uh, affected um, cognitively, emotionally, or spiritually?
Mm-hmm.
And so helping that individual understand, work through the impact so we can preserve identity, so we can preserve dignity, which are overlooked when someone is in need of help.
Mm-hmm.
As practitioners, our job is to address the complaint,
Mm-hmm.
which is ultimately a problem, whether it's nausea, whether it's high blood pressure, whether it's a laceration. Address the complaint and then move on to the next. This is an unfortunate reality of care.
Mm-hmm.
But yet, if we step back and we focus on how that individual is impacted on those things that I listed, and incorporating our colleagues, social work colleagues, occupational therapy colleagues, dietitians, SLP, all of these individuals who have dedicated their lives to essentially helping an individual in a crisis. And it
Mm-hmm.
comes down to that. What is the crisis? And to me, that is intriguing. And that is why I've transitioned into this type of care. That individual is experiencing a crisis,
Mm-hmm.
whether that crisis is magnified or that crisis is contained. And so I'm there to help that individual. So, what other options are there? Well, all those other disciplines of care can help me and I can refer to them. Now, I'm also talking about more conventional stuff too.
Mm-hmm.
But what about the unconventional? Okay, or the other forms of care that are accessible, like naturopathic, chiropractic. Okay, these are very important components of care that an individual might resort to, rely on when they're in a crisis. So, looking at that individual, helping that individual define this crisis, which is a life crisis, of course, because now they're forced to think differently. Let's kind of address that. So, again, going back, preserving identity, right? Preserving dignity.
Yes.
Okay. And how do I do that? Well, do I have to rely on other clinicians, from the naturopath to the chiropractic physician to the, an SLP, right? For example, right? But let's say that individual is compromised spiritually, then I need a spiritual advisor. Okay. Now I can get to that point of helping that individual understand this is where we are and this is what we can do. Right. And so I think as a clinician who practices this type of care, whether it's nurse, physician, so forth, it's important to understand that. So go back to the basics. What is that individual's identity? How do we address that individual's identity? How do we help them preserve the identity? And what do we do to stabilize that individual's dignity? So, I'm speaking like a physician, of course, right? Right?
Yes. Yes.
Identify,
Yeah.
okay, stabilize, right? But yet, this is the bread and butter of what I do, right? It's my
Yes.
foundation. And
Yeah.
so,
I think you mentioned quite a few important pieces there, and it's a collaborative effort, is what I'm gathering
for
from what
sure,
you
it
spoke
is.
about.
It
It's a
is.
true
It is.
collaboration of an interdisciplinary team to
For
support
sure.
that individual.
For sure, for sure. And
Hmm.
the one and the family, the caregiver, the caretaker, they are such a strong component. So again, we support them to
Hmm.
support their loved one, right? And it is essential. It is so important.
Yeah.
Okay.
Yeah.
Um, we overlook that sometimes.
Yeah.
We do, and so we have to do better at that.
Yeah, yeah, it's definitely a collaboration between
Mhm.
the interdisciplinary team and also the family member, and then whoever
Yeah,
that person considers family. It might
for
not
sure.
be necessarily a blood relative, but they consider
Yeah,
maybe
yeah,
a
yeah.
friend,
Family, yeah,
family, whoever they
yeah, for
consider
sure,
as part of their
for
family
sure.
circle.
Yeah,
So I guess we've kind of spoken a bit about this, but maybe you can touch on two things or two ways in which palliative care or palliative care approach improves the life of the individual.
okay. So we'll simplify it. So if there are symptoms compromising an individual who is invested in managing a diagnosis, then we
Mm-hmm.
focus on those symptoms.
Mm-hmm.
How do we address the symptoms? How do we help manage the symptoms? How are we there to help you if something else occurs, another symptom? Okay, for example, right. So that would be, I think, the focus of our care upon introduction. Okay,
Mm-hmm.
and so as the individual ultimately sustains this version of life and ultimately is managing through what treatment they are investing in, we are there to support them. If there is a change in that individual's response to treatment, we support them. If there is a crisis, as that individual is uh, ultimately affected by the diagnosis, then we support them. Okay? If that individual is no longer able to invest in treatment to manage the diagnosis, then we still continue to support them. Okay, so you see the trajectory, okay,
Yes.
from the beginning of the diagnosis, right, to the end, okay, of that in what that individual defines as life. Okay, and so that's ultimately how we can focus on helping an individual, supporting an individual, and improving what they're exposed to. Okay, or at least giving them options to manage what they're exposed
Yeah.
to.
Yeah. We you kind of talked about this in our earlier conversation about some of the misconceptions folks have about palliative care, and one of them being like it's end of life, and it's that thing that you don't necessarily want to have conversation about because you're thinking it's end of life care, right?
Yeah.
What are some other misconceptions that you've come across that people have of what palliative care entails?
Mhm. Sure. So my job is to not sell what I do. Okay, my job is to ultimately be there for the individual. So I acknowledge that it is crazy, okay, to accept that life has an endpoint. We see it. We see it on TV. We see it in our own lives. But yet, that's not going to happen to me. And now there's a diagnosis, an illness that is serious. And so I tell people that accepting is can be exhausting. Acknowledging can be somewhat more rewarding because then we can ultimately introduce options to sustain life. Now, in my conversation with the individual, I do note that your whole life is about surviving. And you do everything you can to survive, whether it's physically, emotionally, intellectually, financially. It's about survival. And then one day, someone or something forces you to think about how survival will ultimately end. And then you enter into this turnoff phase, which is weird, surreal. Okay. And so it is essential for me to explain to the patient that what they're experiencing and these misconceptions about what I can do for an individual is normal because of that. And so, with time, as we develop, meaning the patient and myself and the caretaker and myself, we develop a rapport, a trust. They acknowledge that, okay, I'm not there to accelerate this process. I'm there to ultimately support them through the process. And when I meet an individual, it is important for me to explain that because they're scared. They were scared when they met the oncologist. They were scared when they got the test results. They were scared when they started treatment. And everything they're doing is to avoid the inevitable, which we're all on this path to eventually do. And I tell people we're programmed to do this. As we're programmed to be born, we're programmed to die. And we do everything we can to ultimately avoid that. But yet there is a natural line that we're following. Something tragic can push us off the line, right? It can happen. Whether it's a diagnosis, whether it's an occurrence, an accident, or so forth. But yet we are on a line to be born and to die. And one of my patients once told me, which I found intriguing, we're only here visiting. Okay, there's depth to that statement, of course, but it was like, oh, that's great. Can I use that? Another patient said, yeah, I've entered the one-way road. Okay, right?
Yeah.
It used to be
Yeah.
two ways, now it's only one way, right?
The
So I
one
mean,
way.
it's really cool how people perceive it, and it's fascinating to me. And I'm lucky enough to meet patients who are like, yeah, I know where we're going. Let's take it. Okay. But the majority of people, again, cannot conceive this. And
Yeah.
so the misconception is, are you going to make me die faster?
Mm.
That is the ultimate misconception that I have to work against. And yes, there is research that when the focus is helping someone live as well as they can, meaning introducing a palliative approach, then yes, individuals do live longer. There is data to support that if we are going to be, referring to data. Um, and their quality of life is better. And so you're focusing on living long and living well since the day you're born. Since that first breath, that is your goal. Your goal is to survive as well as you can. Circumstances obviously change that. And now you come to this point where, I need to rely on someone, okay, to help me not get to that point or to help make that transition smoother. That's horrible for the individual. It's horrible,
Yes.
horrible, right? And so my job is to help them address the fact that I am not here to accelerate this process. I'm here to actually iron out the wrinkles, to give options, to give education. Okay. So.
Excellent, excellent. And so I wonder, with that being said, and family is often involved in care. The caregivers are present, the family caregivers are present. How might families be able to support their loved ones in this approach of care? How might they offer support or be there for their loved one going through this health crisis that they're experiencing? How might you encourage them to support their loved one?
Well, for sure. So this actually takes me to introducing, or at least mentioning, advanced care planning, right? So it is important for a patient or an individual with a diagnosis or illness to essentially confirm who is the individual that can be spoken to if they are too sick or ill to speak to or answer questions. And that is actually one of the things that I try to confirm um, when I meet an individual. And so we need to declare who the substitute decision maker is, or if there is a power of attorney. Okay, so and Speak Up Ontario, all right, actually helps an individual go through the important exercises of making this declaration. Okay, so it is essential for that loved one, and for argument's sake, the substitute decision maker or power of attorney, to understand what's important to that individual, to that patient. But that patient needs to be able to communicate this. And sometimes the patient doesn't want to communicate this to the loved one because they don't want to scare them or burden them. And so these are important things that need to come to the surface.
Mm.
But that loved one needs to step back and say to that individual, to that patient, what happens if you get really sick and there's no medicine and you need a machine, for example, to help you breathe? What is it that you want me to say to those doctors and nurses? So I think it is quintessential for that loved one to understand what that patient wants in different circumstances. As clinicians, we need to obviously highlight the circumstances. I can say, if this were to happen, what would you like? If this were to occur, what do you expect? The circumstances can be different, of course, depending on the diagnosis and so forth, right?
Mm-hmm.
So being a voice for their loved one is really the most honorable vocation, right?
Mm-hmm.
Advocating is their devotion to their loved one, right? And they've been doing it since day one. They're there, right?
Yeah.
So I would encourage the loved one to confirm what the goals of care are at the moment, meaning what is it do you want right now? What can we do right now? What would you like me to advocate for right now? And what happens in the future?
Mm-hmm.
But that's all. It's very hard to have that conversation with people.
Yeah.
Very
Yeah.
difficult because people
Yeah.
don't
It is
want to
a very
invite.
difficult
Yeah,
conversation.
yeah. People
Yeah.
don't want to invite misery. Now, some
No.
people are phenomenal. They're so academic about it. It's beautiful,
Yeah.
right?
Yeah.
But then the
Yeah.
majority of people will not invite this conversation because, again,
Mm-hmm.
you've been working your whole life to avoid it. Why would I talk about
Mm-hmm. Mm-hmm.
it and welcome it, right? So it's quite it's so fascinating to see people. My own family are the same. It's just right. And so if I go to my mom and I say, Mom, what happens if you're in this situation? And I give her a scenario. It takes me a while to get through the scenario because she keeps stopping and walking away, and because it's who wants to think of themselves as being vulnerable.
Mm-hmm.
Right?
Mm-hmm.
So that is so challenging for someone to think of themselves as being vulnerable. Yeah. And so
Yeah, it's definitely a challenge, but I have found in my area of practice in terms of nursing that the earlier that conversation starts, the better the outcome
for
for
sure,
the
I
patient,
agree.
for the family
Yeah, I
involved.
agree.
There's so
Yeah.
much more clarity
Yeah.
when that conversation starts early.
Yeah.
Um,
Yeah.
yeah, so definitely is that, but it's definitely not an easy conversation to have.
No, you have to read the room. So as a clinician, like I am not gonna introduce myself and then start talking about advanced care planning.
Yes,
It
yes.
really depends on why I'm there to see the patient, where
Mm-hmm.
that patient is in terms of the diagnosis, in terms of life, and what their concerns are.
Mm-hmm.
Right. And so you have to be able to know when it's time.
Time.
Now,
Mm-hmm.
right, to actually address this. Families, okay, family members rather, have an in, they're there, but yet they have to also feel comfortable, and the patient, it's him or herself, needs to feel comfortable too. So again, go back to identity and dignity. Okay, it always goes back to that. For me anyway.
Yeah,
So
yeah, yeah, very important. So, can you perhaps share with us a success story that you've seen with the use of palliative approach to support that
yeah.
individual in living their best?
So it depends how you define living, right? So is we naturally assume that living is about breathing, walking, talking, eating, and doing, right? And so again, it depends on that individual's life trajectory, right? So I'm lucky, I'm so fortunate to be able to find success in many patients. Okay. And so to me, dying is the most natural process because I'm exposed to this. I'm exposed to my patients experiencing this. And so I see how individuals naturally develop grief, whether it's grief as they witness a crisis, whether it's grief as they anticipate a crisis. And so for me, success occurs when we address that grief. And I resort to a number of my pediatric patients, okay, where the mother and father take on a different role. So as a parent, we introduce this individual to the world, and now imagine being forced to assist this patient, assist this loved one exit this world. And so to be able to help a family do that in their own dwelling is a success. And so that's the only thing that resonates with me today.
Yeah, yeah.
Yeah.
Excellent. I think we're almost wrapping up, but I have a few more questions for you because I think
For
this
sure.
conversation is important for us to have. What barriers have you seen patients experience or families experience in terms of being able to access palliative care or the
Mhm.
palliative care approach that we see being offered by clinicians?
So there are many physicians and nurses who naturally incorporate a palliative approach. They just don't label it as such. Okay. But there are many patients who rely on the system, and the system is compartmentalized. And so, unfortunately, palliative care is its own compartment. And unfortunately, it's introduced as a point of transition of care. And so, the barrier that I see is the patient not being offered this type of care early on in the diagnosis. And for example, a patient comes to the emergency department 3 to 4 times complaining of symptoms brought on by a diagnosis or brought on by treatment. That is a window for a palliative physician or clinician, okay, to be introduced to the patient. Not because that patient is on a trajectory toward end of life, but yet that patient is forced to address a crisis that keeps reoccurring. And so we are equipped to help that patient. Okay. And so the barriers I see is the patient not being exposed to this type of care. Many times it is the clinician who is scared to mention palliative care or palliative medicine. because of the fear of that patient being forced to think as if there's no longer any hope. But yet we infuse hope. We just change and modify and evolve the hope. You can hope to respond to treatment. We can also help you hope to feel better, to live better as you do that. And so that I feel is a struggle and it's disappointing. But again, it comes down to the system forcing us to compartmentalize care. Okay, and that's there is it's a struggle, and there are people that are invested in changing that, and there has been change, and it's about networking and going back to what you said earlier, collaborating.
The collaboration, yeah, yeah,
Yeah,
collaboration is definitely key. And I wanted to inquire of you, in this field, or in this work of palliative care, have you seen evolution in terms of research and new technologies being introduced to help support individuals in living their best? What are some of those things that you have seen, changes in your area of practice?
yeah. So medicine evolves, right? And I think the medicine in terms of medication, okay, essentially changes over time, right? I think what research tells us is that highlighting that an individual is in a crisis, okay, allows us to help them endure what that crisis is doing. Okay, so um, there are different ways of addressing and helping a patient through a crisis, of course. The research ultimately tells us if something works, doesn't work. Now, what we're seeing is that talking to an individual and providing therapy, and one of the more phenomenal components of therapy that has been incorporated into palliative care, hospice care, is dignity therapy. And that to me is a fascinating way of helping someone understand who they are in the moment because of what has happened to them. Okay. Uh, in terms of technology, I think many physicians are are being introduced earlier on. Aside from what I just said, being a component of an obstacle rather, but there are physicians who are being introduced earlier on, and a lot of us can provide procedures, for example, or can do procedures for an individual in order to help them feel more comfortable. And so we're able to do these procedures in their home, for example, okay, as opposed to bringing them to um, a hospital setting, okay, or an outpatient setting. And so I think that is a newer component of care where we're bringing the care to the individual in their home, and there's a lot of data to support doing that, right? And that's a big component of my practice as well. And I think that's important for people to know, that they can have a clinician come to them. And so, going back to what I said, people do not want to feel vulnerable. We work very hard to not be exposed to a vulnerability. Okay, and we invest so we don't have to experience that. And now you are taken out of your comfort zone, if you will, and need help. Sometimes it's inevitable. The institution can provide the help that you need, but sometimes we can bring it to you. And I think that's important to understand, that we can do that, and we should be doing more of
Yeah.
that.
Yeah, yeah, and definitely. I've seen it, in our clients, for our clients with home care, and having that care come to them. It's so
Yeah,
important, because
sure.
I have, and I know there's research to support it also about home care being able to enhance the quality of that individual's life. But you need, with home care, it needs to have a wraparound service. Like, they need that interdisciplinary team supporting them in their homes. It's not just being home, but having that support provided through
Yes.
clinicians coming
Yeah.
to their home and
No,
helping them along their health
absolutely.
journey. So, thanks for definitely
Absolutely. Yeah.
mentioning that. I think to wrap up, one thing that I wanted to ask of you, what kind of inspired you along this pathway? Because I believe when you started, you were more focused in pediatrics. You were also in emergency medicine. What kind of drew
Yeah.
you into this area of specialty?
Uh, Interestingly enough, so I think, I've always been an individual who needs change. Okay, and I, it's fascinating, like, because I think back and say, how did I end up here? But I think this is where I was always supposed to be. And I'm good at changing based on my circumstances, and I think I've been able to do that. Some people are very concrete, and they have one path, and they don't want to deviate from the path, all right, of professional excellence. And I've always been accustomed to kind of like, let's let's kind of go with the flow, okay. So I started off in pediatrics because in I was touched by the love of a child exhibited by a family, a mother, a father, and I was exposed to certain circumstances that su- ultimately motivated me to choose that field. And from there, I essentially loved helping people in an emergency, but I knew that I needed to essentially um, have opportunities, and therefore I then focused on both pediatric and adult medicine in the emergency setting. But ultimately, it was about helping people in a crisis. And so I noted that what makes me happy is when I can sit down and help people develop a plan and then to revisit the plan. And being exposed to patients who were vulnerable because of a diagnosis and being forced to face end of life in the emergency department essentially accelerated my interest and desire to evolve into this type of physician. And so I don't think I made changes based on not liking something. I think I've made changes based on my natural evolution as a health care provider. And so I think back to the family physicians I worked with in Newfoundland and Labrador and how they assisted these patients, and it made me feel really good about what I'm about to do as a physician. And so here I am. It's not that
Well,
interesting,
thank you so
but
much.
exciting. But yeah, but it's
Well,
just how
thank you
that's the only
so
way.
much. This conversation has been so
Yeah.
interesting. I think it's a much needed conversation. And again, thank you for the exceptional care that you're providing to your patients at Northumberland Hills
Uh,
Hospital. I
look,
think they appreciate your care and your time and your effort, that you're putting into your work and what you do there. So thank you again for joining us and just having a conversation with us. I think our viewers will really love to have this podcast on repeat so that they can pick out and pull out pieces of importance to them and their loved ones. So thank you again for your time and just spending time with us today on this podcast.
For sure. It's been such a pleasure. Thank you for the opportunity. Anytime.
Thank
Okay.
Awesome. Thank you so much.
I hope you've enjoyed this week's episode. Please subscribe to see more of our content. Also, like and share this video with a family member or friend that you think may benefit from this information that was shared. See you on the next episode.